Extract 1. Questions 1 to 12. You hear an orthoist talking to a patient called Stephanie Cohen. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Let's take a look at you, Miss Cohen. I hear you took a bit of a tumble 2 weeks ago.
A bit of a tumble? Full-on pelt down the slopes, more like it. Would you take a look at this? My leg is all chewed up. I'm surprised I didn't make the local news. I keep hobbling past the TVs at the lodge where I'm staying, hoping word hasn't got out that there's an amateur skier on the loose in Deer Valley, Utah.
You know, I'm sure nobody's even heard about it. This stuff happens more often than you would think, Miss Cohen. Believe you me, in a few days' time, another tumble would have replaced yours. The main thing is, we've got to work on making sure we can prevent this from happening again in the future. Do you remember what actually happened that day?
Yes. I was working on a particularly tricky bend when I lost control and hit someone else in a head-on collision.
Oh, ouch. Well, at least it's straightforward, and we've got no personal medical history to worry about. It's just a straightforward head-on bash.
Right. I'm taking painkillers right now, but is there anything else that I could do to speed things along?
Yes. Allow me to recommend this specialist institution that specializes in rehabilitation for sportsmen and women who've undergone injuries just like yours. I could probably get you seen to this week if you'd like.
Any idea how long this treatment would last?
You'd be looking at approximately 6 to 8 weeks maximum. However, I think the real beauty of the therapy is that they have a support group of current and past patients that you could seek advice from in terms of recovery times, how quickly you can go back onto the slopes, lots of things. Plus, because they have first-hand experience, they really can guide you.
That's all very well and good, doctor, but I didn't come here for that. I came here for a knee brace. The best you've got, or at the very least an assessment for equipment, and not just any old one that will give me support.
That particular one that you're pointing out is currently out of stock. It will be back within the next 2 to 3 weeks.
You'd like me to wait that long?
I'm afraid so. I will, however, keep requesting it until it's here. Let's go over your blood test results, Miss Cohen.
I'm not afraid. Go ahead.
Well, the test confirms our suspicions that you have a grade 2 MCL injury.
I did feel like the whole area was feeling quite tender. At least now it has some sort of explanation. Even though I don't understand it, it's still there.
Yes. Is there anything that you'd like me to go over for you? Anything at all?
No. I really just want to go home now. This is wearing me out.
I'm sorry to hear that. If you just bear with me for another few moments, I'd like to order your unloader brace so that it arrives on time and you can get to working on your healing.
Extract 2. Questions 13 to 24. You hear a vascular surgeon talking to a new patient called Monica Patterson. The questions 13 to 24 complete the notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, Mrs. Patterson. Your GP has sent you to see me because of some problems with your legs, is that right?
Yes, varicose veins, and they've just been getting worse and worse.
Right. Well, I've got some notes here from your GP, but I wonder if you could tell me in your own words when this started and what's happened so far.
Well, I guess the first time I had problems with my legs was ages ago, when I was pregnant. My son's 25 now, so that shows you how long ago it was. But everyone knows that varicose veins goes with that, don't they? They look horrible at the time, but then they usually disappear again.
And was that the case?
Well, by about a year or 18 months later, they'd gone completely. My legs were looking and feeling fine, and I was back at work then too.
Uh-huh. What do you do?
I was a chef in quite a busy restaurant, so there wasn't much opportunity for sitting around in that job, Doctor, I can tell you. But then, it must be getting on for 4 years ago now, I noticed the veins were coming back. At first I wasn't too concerned, although they seemed to get very scaly, and they itched too around the calves. I tried to follow the advice you find on websites. You know, move around at work, try to keep your feet up on a stool, and avoid crossing your legs.
Mm-hmm.
And I did insist on getting a bit of exercise every day. I always managed to fit in walking around town after the lunch service, just for about half an hour or so.
Good. And what treatments have you had so far, Mrs. Patterson?
I first went to see my GP just because they looked ghastly, and I was a bit worried about them. But he said that he could only recommend proper treatment when they got worse and were painful or I had any complications. But he did tell me I should lose some weight. That's an occupational hazard in my job.
Good advice, though.
Well, I did manage to get it down a bit. Anyway, about a year ago, my left leg really swelled up. In fact, they both look pretty nasty with the bulging veins. And you can see now, my feet and ankles are really swollen up.
Yeah.
Also, when I'm in bed, I regularly wake up with terrible cramps. Last night, I didn't know where to put myself. So, then the doctor did an ultrasound scan to see if there was a blood clot. Thankfully, that was all clear. But we agreed it was time to get my legs sorted. Yeah. The doctor arranged for me to have some injections of foam in the veins. He said it was quite a new treatment. It was just with a local anaesthetic, and I didn't have to stay in overnight, which was good. I had to wear bandages afterwards for a week or so, and then those compression stockings for another week.
And since then?
Well, that seemed to do the trick at first. They felt much better to start with, although I had awful headaches for the first few days, which I gather happens sometimes. Anyway, now they really seem to be worse than ever, so I'm back to square one. I'm thinking that either we have another go with the injections, or maybe I need to consider surgery this time. That's obviously more invasive, and I know from other people that I'd be very sore afterwards and would have to take time off work. That's a consideration too. I run my own hotel now, so I can't just close it for weeks on end, can I? So, what do you suggest now, Doctor?
Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. You hear an optometrist talking to a patient who's trying contact lenses for the first time. Now read the question.
Now, you've had the lenses in for a few minutes. How are they feeling?
Not bad. I thought I'd feel them actually touching my eyes, that they'd be sore or prickly, but I can't feel much at all. My eyes do feel a bit watery, though.
It's okay. You've just used too much solution. Now, in a few minutes, I'll get you to try taking them out and inserting them again by yourself.
I had no trouble taking them out earlier, but I'm not confident about putting them in. I worry I'll press too hard.
That's unlikely to happen.
Things look rather distorted, though. I mean, I can't make out the letters on that chart.
Any of them?
Those lower down.
Let's give things another minute to settle down.
Question 26. You hear a nurse asking a colleague for help with a patient. Now read the question.
Kathy, could you help me with the patient in bed 103? The woman who had surgery 2 days ago.
Oh, yes, she's due for discharge today, isn't she? Does her pain relief need topping up again? I thought she wasn't very comfortable this morning.
Oh, she's on a reasonably low dose, but she's coping. She needs her chest drains removing, though, and she's got herself into a bit of a state.
Ah, well, that's a two-person job anyway, so I'll come with you. Has the consultant seen her? I know there was some concern yesterday about her condition and the level of the fluids draining into the bags.
Oh, he's cleared her for removal of them today, but I think some reassurance might be needed first.
Right. I might just check her analgesia and give her more before we go ahead.
Okay.
Question 27. You hear a senior nurse talking about a new initiative that has been introduced on her ward. Now read the question.
One of our key priorities is improving communications between staff, patients and patients' families. We recently introduced a scheme called Dear Doctor, which involves giving each patient a card where they can make a note of any questions or concerns that they themselves have. They can also talk to their families during visiting time, or even on the phone, and see if there's anything else they'd like to add. The cards are then collected and given to the doctor before the ward round. We're really pleased with the response. Patients used to say that they only thought of the things they felt they needed to discuss when it was too late, so the cards give them a better chance to bring up whatever's on their minds. In fact, it's been so successful that we're going to roll it out on all wards in the hospital.
Question 28. You hear two radiologists talking about the type of scan to be given to a patient. Now read the question.
I've just had a phone call from emergency. They have an 11-year-old boy with right lower quadrant abdominal pain. They're concerned about appendicitis, and they'd like to order an abdominal CT for him.
Do you think that's a good idea?
I was thinking maybe we should recommend an abdominal ultrasound, because then we can spare him the radiation.
Is there any concern in this case around using ultrasound instead of CT? Accuracy, for example.
The sensitivity is slightly less than the CT, but the specificity is almost the same, so I think we can rely on the results.
Okay. It means we can avoid the child being subject to contrast exposure as well. But what would we do if the ultrasound doesn't answer the question?
If we can't visualise the complete appendix, then we can recommend an abdominal CT.
Okay, we have a plan. Call them back and let them know.
Question 29. You hear part of a surgical team's briefing. Now read the question.
OK, next is Mr. Malloy's repeat laparotomy. Any anaesthesia issues?
We don't expect any particular problems. He's relatively fit and well, except for his epilepsy, which is under good control. His BMI is 35.
But will we need the obesity bed?
It shouldn't be an issue.
And what about the epilepsy post-operative management?
He's taking his oral medications, and we can use an IV if necessary.
I know he was in a lot of discomfort after his last surgery, and this time he's going to need a larger midline incision. It may be worth thinking about an epidural. He's certainly at the extremely low edge in terms of pain threshold.
Question 30. You hear a senior research associate talking about a proposal to introduce interprofessional primary healthcare teams. Now read the question.
We're looking at opportunities to improve the effectiveness of health and healthcare systems here in Canada. One of the interventions we're looking at is interprofessional primary care teams, groups of professionals working together collaboratively to provide services including healthcare, social services, and advice to patients within the primary care setting. There's evidence that teams like these can improve chronic disease outcomes, including diabetes, hypertension, and heart disease, as well as mental health problems. There's also evidence that improvements can be made in terms of both access to and coordination of care. Now, the extent to which these teams could affect the costs of healthcare in such areas isn't quite clear within the evidence, but the work we're doing aims to address such issues while looking at the challenges of implementation and evaluation.
Part C, questions 31 to 42. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with Dr. Christine Erickson, who's talking about her research supporting non-fasting lipid blood tests for cholesterol. You now have 90 seconds to read questions 31 to 36. welcome to Health Research Roundup. For decades, people have been asked to fast before they have blood tests to check cholesterol levels. However, a new research report from an international group of experts suggests that this is not necessary. To discuss this research, my guest today is Christine Eriksson from Copenhagen University Hospital, who was a lead author of the study. Christine, welcome.
Thank you very much.
So why did we ever ask people to fast for blood lipids, for your blood fats?
Well, if you ask me, I don't really know, except for that's what we've been doing for so many years. I really tried to read the literature and find some very scientific evidence supporting that it is superior to just taking a random non-fasting blood sample as we do now. And I had problems finding the evidence. There's a lot of arguments people put forward for why you should use fasting versus non-fasting, but really solid evidence that is better, I can't find it.
So was this a tradition rather than science?
I think so, yes. I mean, you can ask me why did it start? I think that some of the early studies, the original publications way back, said that they used fasting samples and therefore everybody thought you had to do that without really thinking why. But those early researchers may have had good reason to do it that way, but there's nothing I've seen that said it had to be done that way. And there's all this evidence now from Canada and the US, 2 excellent studies, one in children and one in adults. And then we have a lot of studies from Copenhagen, and they all show that when you just look at people that eat and drink whatever they usually do, and you take a lipid panel, cholesterol, triglycerides, a very common fat in the blood, then they don't really change very much in response to when you have been eating.
So there is a difference?
Yeah, the difference is in millimoles per litre. So it goes up by about 0.3 millimoles per litre. However, in clinical practice, when you look at triglycerides, you're interested in whether it increases 1 or 2 millimoles, not 0.3 millimoles. So that's what's clinically relevant.
And even with a bad form of cholesterol, that's not going to make the difference between whether or not they put you on medication?
Yeah, that's right. We provide data in this report where we did direct measurement and after fasting and in about 6,000 people, and the correlation between the two methods was, I can't see the difference. It looks exactly the same.
So you moved over in Denmark to this official recommendation about 7 years ago. So what's happened since then? Have there been any issues because of undiagnosed cholesterol levels?
No, everybody was happy right away. Even the laboratories that didn't change right away, they were pushed by patients because there were reports in the media telling them that at Copenhagen University Hospital we're doing non-fasting, so everyone wanted to do it. And I can say today, patients, clinicians, laboratories, everyone's happy. Everyone likes it because it's so much simpler.
And patients like it because they can go when it suits them to the pathologist, so they're more likely to turn up for their blood tests?
Yes, of course. I don't have fantastic good numbers for you, but certainly you hear from so many colleagues that people don't go to have their lipid test because it's so complicated to fast. And then they have to go to work, to have an important meeting, and they can't do this in the morning. But now, doing a random non-fasting, you can come whenever it suits you.
And very briefly, is there any circumstance where you should have a fasting blood fat level done?
Well, this recommendation, it's 21 world experts, many from Europe, the US, and one from Australia also. And of course, when you have so many experts, there's always someone that thinks there's certain situations. We list a few where you can do. For example, for patients with diabetes, the fasting requirements might be an important safety issue because of problems with
Now look at Extract 2, questions 37 to 42. You hear the discussion of a physician with junior doctors on different types of hernias. You have 90 seconds to read questions 37 to 42.
Hello, doctor. Could you please explain to us about different types of hernias?
Well, inguinal hernias are located in the lower abdomen just above the leg crease, adjacent or near the pubic region. At times, they can also occur on both sides of the pubic area, which is called bilateral inguinal hernias. Inguinal hernias, along with femoral hernias, make up the two types of groin hernias and can cause pain that extends into the upper thigh or scrotum. Inguinal hernias can be categorized as direct or indirect. An indirect inguinal hernia occurs due to natural weakness in the internal inguinal ring, while a direct inguinal hernia caused due to the weakness in the floor of the inguinal canal and is more likely to develop in men above 40. The floor of the inguinal canal is located just below the internal inguinal ring. When inguinal hernias are repaired using the tension repair technique, recurrence rates may be more than 15%. However, other techniques used for hernia repair, such as tension-free and laparoscopic tension-free, have much lower recurrence rates of just 1%. A sportsman's hernia is a condition of chronic exercise-related suprainguinal groin pain. Generally, it involves a direct inguinal hernia. Femoral hernias, along with inguinal hernias, are groin hernias, which are very common in women but can occur in men as well. A weakness in the lower groin makes the intestinal sac to drop into the femoral canal, a space near the femoral vein that carries blood from the leg. These hernias are highly prone to develop incarceration or strangulation as an early complication. Incisional hernias appears in the abdomen at the site of a previous surgery that can appear weeks, months, or even years after a surgery and can vary in size from small to very large and complex. Umbilical hernias appear near the belly button or navel due to a common weakness from the blood vessels of the umbilical cord. This may occur in infants at or just after birth and may resolve by 3 or 4 years of age. However, in adults, umbilical hernias will not resolve and may progressively worsen over time. Epigastric hernias are more common in men than women. They occur due to a weakness or opening in the muscles or tendons of the upper abdominal wall on a line between the breastbone and the navel or umbilicus. Spaghelion hernias, a protrusion of intestine or an empty sac through a weakness between the muscle fibers of the abdominal wall, often on the right-hand side of the abdomen. It becomes impossible to detect because often there is no obvious swelling or lump. It develops between the muscles of the abdominal wall rather than protruding through layers of fat. It often develops in later life of men and women when the abdominal muscles become weaker. Hadal hernias are slightly different from other types of hernias because they are a weakness or opening in the diaphragm that separates the chest cavity from the abdominal cavity. These hernias cause reflux of acid from the stomach into the esophagus, resulting in heartburn, pain, and erosion of the esophagus.